Do anyone wants to ask any question before we start? Okay. Can you all of you listen to me?
Yes, Doctor, we are listening.
Yes. Actually, today I will be trying to cover some aspects of trauma. Okay. Before we just start, like I'm sorry. I just sent a message in the morning about different aspects of trauma care. Okay. So okay, so we will be starting with the, like, if you are asked to see a patient with trauma, okay, generally what will be the like things which will be striking your mind? Asim bhai, would you like to start? Like, what are the problems?
Assalamu alaikum.
Walaikum assalam. What will be the highlighted points would you like to mention or think in your mind when someone tells you there is a patient with trauma?
So traumatic patient, the major concern for us is starting from airway and breathing and circulation.
Listen. I'm just trying to have a summary. Just think about it. Forget about the sequence.
Okay.
Like, what are the things you would be as a, like, so that you just revise in your mind, and when you will be telling these things, you will be in your mind. Actually, these are the same things which I sent in the message. So I just want to listen from you that what are the aspects which you should be thinking or you will be considering when you are managing a patient with trauma, because trauma is a number one, and a role of anesthetist. Actually, we are asked to read the hell of knowledge, but actually we are dealing only a few things. Okay, so main majority, either we are taking care of the airway, or we are taking care of the fluid management. Rest of the actual management is being done by the other people. Okay, so but we should be doing everything, because only then we can even have a good plan. Okay, so what can be the aspects which should be in your mind?
First is bleeding.
Okay.
And cervical spine immobilization.
Okay, like airway, and especially in addition to the other aspects of airway, especially there will be risk of aspiration. Okay, and special care related to spinal injury and spinal shock. Okay.
Okay. And another thing is aspiration, you already mentioned, bleeding in the airway.
Okay.
And another thing is our pericardial, cardiac contusion or something, or respiratory, like pneumothorax or hemothorax. And in abdomen, solid organ damage, fractures of the long bone or pelvis is the main concern also.
Like polytrauma, I'm just trying to summarize it. So there will be like aspiration, like airway management with special care to spine and risk of aspiration because of patient usually full stomach considered or are full stomach. So this is one point. Bleeding and recognition of polytrauma, recognition of life-threatening injuries. Okay. Recognition, early recognition and management of life-threatening injury. So as an anesthetist, you will be looking at, of course, bleeding. In addition to that, you will be looking at which life-threatening injury to start with.
With brain injury, traumatic brain injury is the first one, and with the rib cage, there's a lot
Yes.
of, there will be contusion, pericardial effusion or pericardial contusion.
No, try to be, you are right, telling
Yeah.
right, but I'm actually, this is just a brain exercise which I'm doing. We will be discussing each and everything separately, but I just want to, because whenever a trauma comes in your mind, so rib fracture, and then with rib fracture, which is the acute problem, one or two you can mention. Tension pneumothorax is one of them. Okay, and pericardial tamponade, whatever the reason, pericardial effusion, whatever the reason is, the result is cardiac tamponade. Okay.
Okay.
And tension pneumothorax. Actually, this is one of the T's of ACLS. Okay. So, but because there we are approaching in a different way. So here, so if, as you told, traumatic brain injury with the prevention of secondary brain injury, spine care, aspiration vest, airway, and then you are talking about tension pneumothorax and pericardial tamponade, like cardiac tamponade. Okay. So now go a little down in the abdomen.
Then abdominal injury.
Like intra-abdominal bleed with especially liver or any major vessel. Okay. Like, all other things are important. I'm not saying, I'm just trying to scan your mind for what will be the life-threatening or the things which you have to pick in a flash. Okay. Or if they are there and you are being asked to anticipate, your response should be very brisk, because if you don't manage these things, patient can have a catastrophe. Okay. So any other way, visceral injury will be problem, but the most, if there is injury to a major vessel or injury to liver, because liver will have liver or kidney or spleen, they will have very high blood flow. Okay. So so this thing, and then long bone fractures. Okay. So long bone fractures with the association package deal which comes from that, bleeding and embolism, fat embolism, pulmonary embolism can occur. Okay. And then
pelvic fracture is the most important because there's a life-threatening hemorrhage.
Yes, pelvic fracture, internal bleeding, pelvic fracture, and then any other long bone. Okay. But usually the long bones of the lower limb. Okay.
Lower limb. Okay.
Actually, I said long bone, but actually it was lower limb. I was trying to say lower limb mainly. Upper limb it can be, but it will be more dangerous in case of lower limb. Okay, and then some of the consequences which you will be dealing will be following bleeding. Okay, like following bleeding, you are either losing the volume and patient going in shock. This is one aspect. And the other aspect will be actually which you will be created by you yourself, like development of hypothermia by giving fluids, creation of dilutional coagulopathy or dilutional consequences when you are giving fluid. Okay, acid-base disturbances, and the creation of lethal triad. Okay. So these are the things which you will be facing or creating by yourself. Okay. So if this background comes to your mind, and then one aspect will also be related to you will be the, as I mentioned, was pain. Okay. Pain control, or like how can you manage, or what will be the, okay, just to scan what will be the most painful condition which you can treat, because there will be, if the patient has brain injury or head injury, even there is a pain, but actually there you don't have to do anything for the control of pain. Okay. But what sort of pain in trauma you can control? And can you just tell some of the names?
Burn, I think.
I'm sorry?
Burn.
Burn. Okay.
Burn, yes. Burn.
Okay. Burn. And what else?
Fractures, hip fractures.
Long bone fracture. No, I'm just thinking, like my question was that what are the treatable from your side, from anesthetist side? So like rib fracture. Okay. In the rib fracture, you can give a bedside intercostal nerve block, you can give erector spiny block. Okay, you in the case of femur fracture, you can give ilioinguinal what is that nerve? Inguinal iliohypogastric block or femoral nerve block. Okay, or the which we discussed pang block. Okay, so these are the blocks you can give in case of painful conditions, mainly which will be dealing to you with the rib fracture. Am I right, Dr. Asim bhai? Any other painful condition treatable something to your mind?
What is most common? This hip fracture with femoral nerve block.
Femoral nerve block. Okay, one of it. Yeah. So that will be one of the things which can be asked actually. Fascia iliaca block or femoral nerve block or pang block, whatever you want to say. And as I told you, this erector spiny block has gone a lot of fame because it's simple. It can be done even with the landmark technique. You can give it somehow. Okay, and it's very easy to give. And intercostal nerve block. Okay, so these are the aspects which you will be you should be targeting or thinking when you are manage any patient with this one trauma. Okay, so now we can start with a scenario, and in which now, because we have discussed the pearls, the important things, and so whenever you are describing the scenario, it will be easier for you not to forget any of them. Okay, so you will be getting help from some radiology, you will be getting help from your basic resuscitation manuals, you will be getting help from multidisciplinary team. Okay, you will be shifting the patient somewhere to do some intervention or diagnostic test like CT scan, and then you can have a laparotomy or laparoscopy or thoracotomy or insertion or pain control or judicious fluid management, initiation of massive blood transfusion protocol. Okay, so these will be things, or of course I forgot in the airway, manual inline stabilization and cervical collar. Okay, and minimum manipulation of the neck. Okay, so these will be things which you will be doing. Am I right? So now we will take a scenario that we have a patient who had RTA, okay, and has multiple injuries. You are gone to see the patient. So how will you what will be your initial response? What will you do? Rabia, you would like to take?
Yes, sir. Assalamualaikum.
Walaikum assalam. Yes.
Since this patient is of multi trauma, and my approach would be according to ATLS guideline, the teamwork, dedicated team of trauma would be there, using horizontal approach of dealing multiple tasks at a time, and multidisciplinary team, and the basic team or basic approach would be primary resuscitation, primary survey and resuscitation, secondary survey and definitive treatment. Then I would these would be the main chunks, and I would also involve activate multi trauma protocol, massive trauma protocol, and also
Rabia, you are a little bit distracted. Okay, we were discussing it as a pearl. Okay, and now it's real-time scenario. Okay, so in that real-time scenario, you have to tell what you are doing. Okay, so your initial approach will be airway, breathing, circulation, and call for help and involvement of whatever you want. What you are saying right. You are not telling wrong thing. Okay. But you have to say that my approach will be airway, breathing, circulation, and as we discussed that there will the priority will be, as I send this audio message to you people as well, that your approach will be for the at the same time you will be initiating that the trauma team, and side by side to airway, breathing, circulation, your priority will be to control any ketoacidosis bleeding. Okay.
Sir, I would, yes, sir, I would immediately, then in my team, would immediately allocate the role and call for help and deal the patient with ABC approach. I would maintain airway. If the GCS is less than 8, then I would intubate the patient with manual inline stabilization unless the cervical spine injury is ruled out. Then I would pass IV lines and start the fluid resuscitation and send the baseline lab, all the labs, and also arrangement of blood and blood products. If according to ABC score, patient have massive bleed, as patient is of multi-trauma, so there is high likely chances of bleed. Massive bleed, so I would activate the massive trauma protocol. My primary survey, I would resuscitate the patient immediately and look for the life-threatening injuries and stabilize patient. In primary survey, there would be immediately catastrophic hemorrhage control with the tourniquet or bandages, and then I would look for the breathing. In breathing, I would look for life-threatening injuries like tension pneumothorax, open pneumothorax, massive that is flail chest or cardiac tamponade, and then I would alongside I would all the tasks would be done in horizontal approach. I would attach the fluids. And
what is this? You are using this word frequently. What is horizontal approach? Is it necessary to tell?
Yeah, sir, it's a teamwork in which multiple tasks are doing.
You said that you are controlling bleeding. Anesthetist is supposed to control the bleeding.
No, sir. I would that would be like initial maneuvers of controlling the with the tourniquet or some bandages until the definitive step is or
because
definitive.
Actually, I'm sorry, I'm interrupting you again. Actually, you are missing one trick. Okay, when you did not, up till now, you did not mention about prevention of secondary brain injury. If it GCS alongside, you have to tell. Alongside, you have to tell that airway management should be done with Mills and special care to spine. You did not mention this word because these are more important than the words which you are using. Am I right?
Yes, sir. So I have mentioned about the spine, but I didn't mention about secondary brain injuries.
So this is
yes,
what else you want to mention?
Yes,
because
sir,
the words which you are using are only waste of time. Okay, you are not telling the wrong thing. I am again telling you that you just imagine it's 4-minute job, my dear. In 4 minutes, 5 minute scenario, if you are not telling the important things and you are jumping to the less important things, it will not help you. Okay. So care of spine, as I have told all the answer before we started actually, but again you are missing it. Okay, so traumatic brain injury and the prevention, because primary brain injury will be there. Okay, and you have to prevent, because you mentioned that if GCS will be lost, then you will intubate, maintain the airway, but you did not mention anything about Mills. You did not mention anything about the cervical spine care. Okay, and yes, and as you told that there will be horizontal approach, so it will be very appropriate. So you will be involving the surgical team. You should say at the same time that because you will be needing the surgical team, you will be needing the neuro team. You can mention the names: surgical team, neuro team, radiological team. Okay, because you will be, for example, you are saying I will be looking for tension. How will you pick the tension pneumothorax? You did not mention anything about it. If there is like if you intubate and there are high airway pressures are coming and patient is seeming to have some chest trauma, okay, so how will you confirm it that is there is chest trauma?
Okay.
You can do some radiological scan, or you can involve the surgeon to initially you can deflate it. So you have to mention at the same time, if tension pneumothorax is there, I will immediately deflate. Or if the open pneumothorax, the surgical, I will request the surgical team to pass the chest tube. Okay.
Yes, sir.
And like if there is when you involve the radiology, you will be doing the chest scan, bedside chest X-ray, and at the same time while you are managing these things, the radiology team will be doing this fast scan to rule out any abdominal bleed, and the orthopedic team will be managing the if any fractures, they will be starting doing anything for that. Okay, so multiple teams will be working together. So your words of horizontal will be more effective if you are telling like that. Okay. I hope you understand.
Yes, sir. Yes, sir.
Okay. So then you will be activating that, as you told, there can be bleeding. So you will be activating the massive transfusion protocol team. Massive transfusion protocol to have the blood and blood products. Okay. At the same time, you will be taking large bore IV cannulas and if needed, even initial after initial
rapid infuser devices and
rapid infuser devices have like this one
level 1 infuser.
Level 1 infuser and intra-arterial blood pressure monitoring. Okay, and fluid warmers. Okay, so because you don't have to make, unless there is cardiac arrest, unless there is you pick some neurological injury and you don't want to warm the patient, that is a separate thing.
At this time, when I'm managing for the catastrophic hemorrhage control or for bleeding and pushing the fluids or blood products, if patient is not stabilizing, then I would take the patient for damage control resuscitation.
Yes. So you have to mention these things, na? Damage control resuscitation, and once you started the fluid management, you will be targeting the ABGs and you are preventing the lethal triad. Lethal triad. Okay. You are preventing.
Yes, sir.
You are preventing the lethal triad. Okay, and you are trying to. Okay, so Asim bhai, you have asked the question. So tell, what are goals of DCR, damage control resuscitation?
Yes, our goal of resuscitation is temperature monitoring. Temperature should be more than 36 degrees centigrade, and hemoglobin should be more than 7 gram per deciliter. With fibrinogen level, if there is, so it will be around 1.5 to 2 milligram per deciliter. And in ABGs, pH should be more than 7.25, with lactate should be less than 5, and I think this is the one.
Urine output.
Mean arterial pressure. Yeah, mean arterial pressure more than 80.
Cerebral perfusion pressure and mean.
Okay, so whenever you are mentioning the temperature, please do mention unless there is some neurological problem, because in that scenario you will not go for you should have that thing in your mind. Okay.
Okay.
So like what will be our target for vitals? You are not correcting it 100%. Okay, you will just try.
Would be allowed for some limited time in order to control, in order to avoid the massive bleed and maintaining the perfusion and minimal optimal level of the vital organs.
Okay, so like what other things are component of damage control?
Component of damage controls are permissive hypotension, hemostatic resuscitation, and damage control surgery.
Okay, so what, like you see, practically speaking, you are controlling the you are just trying to initially resuscitate with not 100% correction. This is one thing, okay? And you can say homeostatic conditions. You don't want too much acid-base disorder. You don't want hypothermia. You don't want, because hypothermia will lead to coagulopathy and acidosis. So you are preventing from lethal triad. Some of the more important thing you can say that part of damage control, actually, this is also part of damage control resuscitation is packing. Okay, packing of the wound or immediately burr hole. Okay, not full craniotomy. Instead, even burr hole is actually damage control. Okay, this is not for the permanent or more invasive. Okay, so
So won't these things be included in damage control surgery when we say that damage control surgery?
Listen, there is no difference. Listen. You are not doing surgery. Actually, this is a surgical topic, but unfortunately, they are asking us. Okay, so these are the aspects which you can or they can expect from you. These are the some of the, because you don't want abdominal compartment syndrome. Am I right? Okay, because abdominal compartment syndrome, if it occurs, it will call organ dysfunction. Okay, so this initial, if there is either there is blunt trauma or there is a penetrating wound, this will be a little different. If there is penetrating wound, bleeding will be occurring. If there is blunt trauma, maybe apparently no bleeding is outside, but what about, is it okay? In that event, what will be the things which surgeons will be doing? It's not your job, but what are the things which you should be knowing that they might be doing? What's that? Please, Zishan.
They would do laparotomy.
Before laparotomy, they will immediately do laparotomy. They will do the fast scan, and they will be trying to find some free fluid. Okay, or they can do diagnostic peritoneal lavage. Okay, so these are the things which they can do before they go for laparotomy. Okay, or abdominal girth is increasing, patient is hypotensive despite resuscitation. You put the Foley's and either you are not able to pass the Foley's or hematuria, frank hematuria is coming. So these will be the warranting signs. Am I right? Despite there is no bleeding open, there is no open bleeding, but still, just like that will be like you put the endotracheal tube and now there are very high airway pressures are coming. Okay, so this will be warranting that maybe there is and you see or palpate and you had a chest x-ray, you find there is fractured ribs. So now this will warrant that there may be tension pneumothorax developing. Okay, so this is how you will be engaging the patient. Okay.
Yes, sir. Right.
Okay, Rabia, do you know what is whiplash injury?
Sir, this is an injury of the cervical spine that usually occurs due to we can say a motor vehicle accident at low speeds, in which there is hyperextension and then hyperflexion of the neck. Okay. And it causes a compression on the spinal cord. This is whiplash injury.
Okay, so what will you be doing at that time?
We have to stabilize the cervical spine. Mm-hmm. Because we don't know, with the whiplash injury there might be unstable cervical spine, and even for the spinal cord we have to immobilize the spine first of all.
Like actually there will be more. No, you are absolutely right, because whiplash injury means there is potential damage. Okay, there is potential damage, so actually psychological problem is more. Okay, there is a big psychological impact. Okay, because if
yes, cervical... there are also symptoms which the patient can develop, like neck pain, muscle cramps, and then even the numbness and tingling in arms.
Mm-hmm.
Sir, can you explain it again, please? I couldn't get the idea of the whiplash.
Yes, Zishan, please say again. there is what in first of all, in which surgery, in which sort of patients you will expect, like what has happened because of high speed,
Low speed.
low speed or high speed?
Yes. No, it's low speed always.
Okay, then
you know, whiplash. Whiplash is just a whip that you know, the horsemen used to tame their horse.
okay,
Just like that, in a we can say what kind of the movement of a whip is like the whip goes in one direction one time and then in the other direction altogether in the opposite direction. Just
okay.
like that, when
So there
if
will be
our car-
hyperextension and then hyperflexion or other movement on the neck. Okay.
on the neck.
And then there will be as I told you that there can be pain, there can be actual injury as well. Okay. And I'm unable to find this. Where is it written? Low speed injury. I'm not finding it. Usually it is written to have acute.
I'll send it to you.
Huh?
I'll send it to you. I think I found it somewhere.
Okay.
Not in any kind of medical, but otherwise.
Okay, so they can ask you a few words about whiplash injury. Okay, so you should be able to, that this is a sudden injury, like as Zishan explained, in sudden way that there is sudden movement, hyperextension, and followed by hyperflexion. Okay, so I will just let me show you the picture.
I just sent it on the Viva group, sir.
Just a second, I can show you. I will try to show you. Just a second. Does anyone else of the participant have, because I don't have very good excellent concept of this topic actually. Okay, so they are saying that a seat is going forward, patient inertia, patient is moving back, and then there is hyperextension, and then when it is touching, then it is going forward, like, okay, they are saying like that. And the words which they have written here is acute whiplash injury follows sudden or excessive hyperextension, hyperflexion, or rotation of neck affecting the soft tissue. Okay, it typically results from rear end or side impact motor vehicle collisions. They have not written slow. Patients commonly present with pain and stiffness in the neck, headache, upper back with or without paresthesias. If it is persisting for more than 3 months, it will be chronic. Okay, and it has a lot of.
Is this article present in your drive?
No, I have found it from some one's drive. Okay, I don't need to use my own drive.
I couldn't find it, sir. I tried to find it.
My problem,
but I couldn't find it.
It's not my problem. It's your problem. If you are not able to find, is it my problem or your problem, my dear? Okay. Actually, whenever I show anything, the people are so surprised. Oh my God, from where did you find this? We never found this. I don't know from where are you digging the hole if you are not finding. I send in the morning. If you are not able to find it, Zishan, but where should I hit myself? Just tell me. Okay, so don't worry. Don't overfeel my beautiful words. Okay. So actually, yes, you, because you are immune now. I have given you so much doses that I want you to be immune. When the examiners are making fun of you or they are teasing you, it will be very normal to you. Okay.
Yes, sir.
Okay, so actually this few words, they will not ask you as a detailed topic most probably, but I think you should, because I'm sorry, I don't have too much knowledge about this topic. So,
sir, what I get from it, that it leads to only the soft tissue damage of the neck
actually
muscles.
it is, you can say it is before, it is before proper neck injury. Okay, that's the simple word, that it is shaken. Okay, like I can say like that. Okay.
Yes, sir. So Dr. Zishan was saying that at low speed, there is written less than 14. Sir, the previous page, there was the speed less than 14.
Where is it? Here?
Sir, it's
Yes.
less than
Yes,
14.
Dishan. Yes, it is low impact. Fine. Thank you. I was not able to find it. It was MPH, so I was not able to pick it. Okay. So I hope we should not waste more time than this on this small thing, but you should have an idea and you can read further from this article, which is there in the trauma Google Drive link, which I sent in the morning. Okay. And your approach will be the same, like you will be seeing, and actually there will be, you can put the collar, you can give analgesics, you can give some psychological support, you can give some physiotherapy, okay, and muscle relaxants. This will be, I think, the treatment for this, with as they have written, patient psychology, absence of radiological evidence of injury, okay, in the symptomatic patient group further complicates the treatment process for this condition to leave bed rest, immobilization of the neck. Okay, I hope this is enough. Am I right? So let's move to the other aspects. Okay, so you know what about the fluid? Okay, which fluid would you like to give and which fluid you would not like to give in trauma? Who wants?
Should be given.
Rabia, just a second. Asim bhai, would you like to say something, or anyone else, please? Anyone more?
Yes, there is 2-3 articles I have read about this.
Just a second. Just a second, Asim bhai. Dr. Amika, you said avoid colloids. Why would you like to avoid colloids? First of all, I will ask you this question. Dr. Amika Onaya, yes, please.
Yes, sir. When we have an associated head injury in patients,
okay,
and we give colloid,
okay,
the protein in the colloid will leak out of.
No, I'm sorry to interrupt you. Colloid remain in the circulation for more time, so they are not associated with brain edema. Actually, if you are giving more crystalloids or you are giving hypotonic fluids, then it can cause brain edema.
Okay.
Okay, so you understand? So that's what you were saying, that it will not remain in the circulation and come out. Am I right?
Yes.
No. So please correct your concept. Colloids will actually be better because you are getting the same result with one slap rather than 4 slaps. Okay, that one slap of colloid is as effective as 4 slaps from the crystalloids. Okay, and among the crystalloids,
that's true.
Among the crystalloids, actually the hypotonic solutions will not go. Okay, Asim bhai, please continue. Don't mention the name of the articles. Tell me what I am asking you.
Yes, okay. So for the large volume of the crystalloids, there are chances, you know, for the 0.9% saline, there's chances of metabolic acidosis.
I'm sorry. What you would like to give? For example, if there is a patient with the hypotension, initially you are expecting hypovolemia. So which fluid will you give?
Okay, so for the ATLS, the latest guideline 2018, they suggested that give 1 liter of crystalloid initially if adult or pediatric more than 20 ml per kg, you can give, and then you can resuscitate after that with the blood and blood products. For the colloids and crystalloid, there are a lot of like for crystalloid, there is dilution, coagulopathy, there is increasing in mortality, there is increasing in bleeding tendency, and for colloids there is nephrotoxic toxicity and anaphylaxis or coagulopathy involving in this one. Even albumin, they said there is no benefit. So they said to give 1 liter in the beginning, and then you can go for the blood and blood products.
No, but what about colloids?
Colloid, there is one crystal study they have done, and they said there is no benefit for the colloid or crystalloid.
No, but tell me one thing: if because you see, if patient is really bleeding, okay,
Yes.
And because whatever studies they are doing, there is a special scenario for that study. Okay. So that study cannot be generalized. Okay. So I will suggest you that if you are saying that initial, for example, because what will happen, that arrangement of blood and blood products, even at the earliest time, will take 10 to 15 minutes. What will you be giving in those 10 to 15 minutes? You don't have any other option. Okay. So at that time you can say that your main aim is to build up the volume. Okay. So if the volume you are able to maintain, then you can do anything else after that. Okay. So till that time you will say that yes, there are some like because the thing is that whatever fluid you are giving, till the time you don't give blood and blood products, it will be useless. Okay. So if the patient is having hypovolemic blood loss, or it's like massive bleeding, okay, with the patient in full shock, you don't have any other option actually. Okay. You have to replace it with the blood. But till that time, like you was mentioning that yes, you are saying that you will be starting with crystallite, and if you don't get blood, you can give it, like it's not contraindicated. Okay. So your priority will be to immediately maintain the volume till the time you get the blood. Okay. What else? So what will be the special scenarios? As you told that if you are giving excessive normal saline, there are chances of hyperchloremic metabolic acidosis. This is one thing. What about dextrose containing fluid or hypotonic fluids? What will happen?
So there will be like it will cross the this vessels, and it will cause pulmonary edema and edema of the limbs, and it can go for this.
You are missing a very important point. If you are giving dextrose in a patient with polytrauma,
yes.
It will worsen the neurological injury.
Worsen the neurological, yeah.
Okay.
Traumatic brain injury.
Yes, hyperglycemia is one of the major factor which can badly damage the neurological outcome after polytrauma or after brain injury. Okay. So this is an important thing. So we talked about different crystalloids. Among that, actually plasma light is the best solution in the sense that there is no lactate. Okay. So plasma light is balanced, any balanced salt. So plasma light or ringer lactate will be a better choice. Okay. Initially you can give 1 liter of normal saline, and then either you have to preferably if the blood loss is hemorrhage is massive. By the way, can anyone just tell how do you classify hemorrhage? Hemorrhage classification should be.
There are 4 classes of hemorrhage. This is class 1. Hemorrhage is more than 15%, and class 2 is 15 to 20%, and class 3 is 30%, 20 to 30%, and class 4 is more than 40%.
So in which category the blood blood transfusion will come?
Category 3 and 4.
Okay, and what about if the patient is already anemic or was already anemic? Would you like to go till that point?
No, we have already mentioned about the goals of this damage control. So
no. You are right.
You
are right, but actually different. It will be different in different patients. Okay.
Yes. Okay.
So you have to trust on the clinical parameters which you are seeing. Like my point is that you are saying you started with the word of loss. Am I right? 15% loss, 30% loss, 40% loss. So number one thing is that it's not possible for you to accurately assess the loss, how much loss has been occurred. So what is in your head?
There are other parameters, the hemodynamic parameter.
That's what. So that's what you understand. Actually, again, you know, again and again, I will say, please try to understand the scenario. Okay. Like if, for example, if they have asked you that, well, what will be the transfer, like when will you be giving the blood? So because in operation room scenario is different, okay? And the practically you will say that because in that scenario, you are not able to accurately judge because as much as blood bleeding has occurred, you don't know, okay? So you have to trust on the clinical parameters which you are getting, like generalized status of the patient, and the vital signs, and the if you have done the hemoglobin at that time, like ABGs you have done, and you can have the result of the hemoglobin or hematocrit. Okay, so that will be more important rather than, because you cannot identify. Okay, because
we can say that we can go with mental status with the urine output, which is obvious we can measure.
Yes, obvious. Of course, you see in that, because there is, there are two things. Number one thing is that the bleeding occurred in front of you. Okay. Then you can evaluate that initial hemoglobin was this one, and now this patient has bled this much. Okay. So because this is another point, that under the anesthesia, sometimes you are not able to pick the signs 100%. Okay. Because there will be effect of some medications or something. Okay, so this is one scenario. The other scenario in this one is that you will have to be analyzing the patient with the labs, like you will do the ABGs, and then you can decide how much blood you want to give. Okay, and of course the clinical scenario will be telling you, like if there was acute abdomen, there was some blunt trauma, and then they open it, they found active bleeding occurring. Okay, active bleeding occurring, or they found the clots. So it means that now you can say by surety. Okay, so these will be things which you should be considering.
Sir, at this point, one thing I want to add, that transamin should be given as soon as possible. They say within 1 hour of the trauma, because the DIC started along with the bleeding in traumatic.
Like separate, along with these things will be all the, like as you were telling to start with, that this one tourniquet, okay, or putting the packs, okay, or even for example, if there is bandages, like by whatever way, either doing the diagnosis, okay, and finding the possible immediate cure. Okay, so like level of consciousness, skin perfusion, like cardiovascular responses. By that, if there is thready pulse, okay, so you have to respect it, because that will not be wrong. Okay,
capillary refill, tachycardia.
If the patient, in addition to tachycardia, the character of pulse, okay, character of the pulse will be very important. Only tachycardia can be because of stress, okay, but thready pulse will not be there unless there is hypovolemia, or there is like weak pulses. You are not able to feel them very nicely, like you are not cold peripheries, the temperature of the peripheries, sweating, they will tell you. Conscious level, if patient is awake, for example, and awake in the sense the patient does not have any head injury, not necessarily polytrauma means head injury. Okay, there can be only abdominal, like there is a firearm, okay, or there is like penetrating abdominal injury, patient can be hypovolemic, okay, but there will be nothing with the brain. So, and in that case, if the patient now is losing conscious level, it means that now it's significant bleeding. Okay, so these are the things which you should be. Some words which we actually missed. What will be the consideration of passing this tubes, like NG tube, like Foley's, like airway? Like tell me that what will be the consideration when you are managing the airway? Actually, we have discussed. Just quickly repeat it. What will be the consideration in patient suspected spine injury?
Sir, we would maintain airway with if the GCS is less than 8 with maintain airway with the rapid sequence induction and manual inline stabilization. And
Keep
another
the
thing.
collar. You will not necessarily remove the collar unless you are not able to intubate. Then you will be using gyroscope, which will decrease the chances of decrease the need of neck manipulation. Okay, because the blade of gyroscope is quite acute angle. Okay, and you don't need to do the neck manipulation or too much neck extension. Okay.
Video laryngoscope and Buji, or if patient is cooperative, then we can use we can do awake fiber optic intubation.
Awake fiber optic will have very limited scope. You are right. You are absolutely right. That if this can be one of the thing, but actually in the in the conditions in which you are intubating, actually there will be patient's conscious level will not be that you are able to do awake fiber optic. Okay, and we did not actually mention about the facial trauma and facial injuries, neck injury. Okay, because these can also be there. So in that scenario, you should be ready for tracheostomy, because in that scenario, you may not be able to intubate. So the surgeon you should not be doing hit and trial, because if you are doing the laryngoscopy, you are not able to see anything, or if bleeding is occurring and it can block the airway, there will be low threshold for tracheostomy. You will go for tracheostomy to control the airway in a better way. Okay.
Yes, sir. Sir, after doing primary survey, we'll and resuscitating the patient, we will move toward the secondary survey, in which we will take a quick ample.
I'm sorry, Rabia. I'm sorry. This was for our airway. Any consideration for Foley's or gastric tube?
Yes, sir. If we consider these patients as full stomach, so we would pass Foley's and also an NG tube.
No. The only thing I just want to listen, or this should, they may, because maybe this is extra. I'm telling you that, but urinary catheter should be done by a specialist if you are suspecting any trauma, because you can inexperienced person can do damage. Okay, because if there is a pelvic fracture, there are chances of involvement of genitalias or urethra. Okay, or ureter, so there can be bleeding.
So what about NG?
Yes, now for NG, what will be the problem?
NG, yes. If base of skull fracture is suspected, then nasogastric should not be put. We should put in a orogastric tube.
Okay, what else? Is it necessary to pass NG or OG, whatever?
Sir, it is not necessary to pass it, but if
actually these are the things which we know, very well. I just want to recall that actually whenever you are passing NG, you are opening the door for aspiration.
Yes, sir.
Because you are finishing the
tone of the sphincter,
lower esophageal sphincter tone. That's what I just want you to just revise in your mind.
Okay.
So now you can tell about secondary survey, because most of the important aspects we have covered already. Okay. So what will be the secondary survey?
So in secondary survey, we would, they say we should take, after resuscitation and stabilization, we take a quick review of any injuries and quick ample history, in which is mnemonic for A is for any aspiration, M is anesthetic history, M is for medical condition, P is for
A for allergy.
oh, okay, sir.
A is for
A is for
allergy.
allergy, M for any medication, medical history. P is for sir, it's
Past
I
illness
forgot.
or pregnancy.
Past illness. Yes, L is for last meal, and E is for event leading to the to this scenario. And also all the tubes in every orifice should be inserted. And during this survey, if we find any kind of destabilization, we will start primary survey again or resuscitating the patient again. And after stabilizing, we will shift the patient to definitive for definitive treatment or care.
Okay. Okay. So you see, so there can be either blunt trauma, penetrating trauma, or burn. Okay. So burn, because we have to discuss separately. So I did not mention much about it because there can be the blast injuries. Okay. So in our exams, they can ask about blast injuries as well. Okay? So that will be a combination of number of injuries, or if there is fall, there will be multiple fractures. Okay. And like the things related to neuroanesthesia and neurological examination, actually we discussed before in our previous discussions. Okay. So you will be checking the conscious level, the same details you will be doing it. Okay. What special, anyone wants to add something?
So some words about trauma-induced cochleopathy, and
Okay.
also
What will be those?
so trauma-induced, actually cochleopathy starts with the trauma, and it occur because of hyperperfusion of the endothelium. Actually, there is a release when the endothelium is hyperperfused. There is release of thrombomodulin, which causes direct inhibition of factor 5 and 8. Which lead to inhibition of the thrombin generation and ultimately formation of the fibrin. And also thrombomodulin directly attached with the thrombin, which is already formed, and this also leads to the decrease in the formation of fibrin, and thrombin and fibrin. The other thing the thrombomodulin do is that it inhibit the plasminogen activator inhibitor. It inhibit that enzyme, so leading to acceleration or increased quantity of tissue plasminogen activator, which convert plasminogen into the plasmin, which cause the hyperfibrinolysis. So both of these conditions leads to DIC or increased bleeding.
Okay. Okay. So anyone else want to add?
So for this thing, sir, we give transamine to the patient, and also the dedicated blood products which are needed. As Dr. Asam said, we have to set some targets about resuscitating the trauma patient.
Okay, so what I missed one thing which I was thinking there, because there are some articles on it as well. What about pre-hospital trauma care? This is most likely they will not ask you, but as they can ask you about transfer as well, they can ask you about pre-hospital care as well. So it will be actually because usually it should not be asked, because it's usually done by the paramedics rather than doctors. Okay, but they will be trying to do the same things like immediate care. They can do manual inline stabilization. They can, if the patient is having cardiac arrest, they can start the BLS or and they can communicate the things. Okay, they can because in our part of the world, we don't have the proper resuscitation things, which are specialized ambulance, or actually they are like they are just like hospitals moving in the ambulance. Okay, so they don't have the all the facilities and all the things, but they can have the same primary survey or secondary survey, and they can do the same thing. Even they can do needle cricothyrotomy as well. Sorry, yes, needle cricothyrotomy, or this needle decompression of the chest as well. Okay, So
Sir, also application of tourniquets or pelvic binders and those sandbags and neck stabilization maneuvers, sandbags and adhesive tapes on the neck and the chin. These kind of stabilization, these are done pre-hospital, and the fluid resuscitation.
fluid
And,
resuscitation can be started like proper information to the care where they are shifting. They can be do they can do. Okay. So I think anyone wants to add some, because actually it's a very big topic. Okay. So I have just tried to give you an overview and just try to give you a little out of book approach. Okay. Just to clear the concepts and just to approve, because you see books are available for everyone, but still people fail in the exam. Why? Because they are not able to chalk out what they have to say. Well, okay, just few words. What is flail chest?
Sir, a flail chest occurs when there are
Okay, please tell Zishan.
a flail chest is, sir, when there are two or more fractures in one rib, or there is one fracture and dislocation of the rib at the costochondral junction. This basically causes the rib, that the particular rib to be sunk in, and in this, when the patient is
What is this movement called as? Paradoxical movement.
Paradoxical movement, yes.
Paradoxical movement, and it is
during
sucking
inspiration,
in the air. Yes, sucking in the air.
yes, sir.
And like it is going in one-way valve. It creates a one-way valve, which is leading to
Pneumothorax.
yes,
Tension pneumothorax.
tension pneumothorax. Okay. It can lead to, or it can lead to lung injury, pulmonary contusions. Okay. So this is one of the thing which we missed, and they similarly, like they do laparotomy, they can do thoracotomy or VATS or laparoscopy. Okay, they can do the things, not necessarily laparotomy, but usually they will do either fast scan or diagnostic peritoneal lavage before doing opening. Okay, with of course the clinical features. Okay, so I think if this scenario comes, now I have given you an approach, so you can approach. And by the way, if someone listening from the people who are appearing, who will be appearing in the Saudi Commission exam, this is a must ask topic. Okay, this topic they will definitely ask you in a trauma patient. What will be your approach, because it's one of the leading cause of mortality and morbidity in Saudi Arabia. Okay, so you should be covering this topic in a way. Actually, for Saudi exam it will be very easy, because they will be touch and go. They want you to tell the correct approach. Yes, Tayyiba?
I just want to add 2 or 3 things. I don't know, you people might have discussed about this or not. One is the analgesia of these trauma patients.
We have discussed. What else?
Okay, the antibiotics and the tetanus toxoid prophylaxis.
Yes. Okay, fine. Antibiotics. What sort of antibiotics would you like to give?
For the open fractures, which may require broad spectrum IV antibiotics. For the wounds, so the prompt consideration of the tetanus prophylaxis should be there.
Just tetanus is something else. But what about antibiotics? Just tell me one thing: the usual wounds, unless they are infected or they have some fecal matter, are they sterile? Yes. Or infected?
They're sterile. If they're not,
they're sterile. So I don't know. Yes. I don't know how much this antibiotic is important, because there are hell of the information which you need to tell. So please try to say it at the end, Tayyiba, because the examiner can catch you on this point. Like you surrender even in front of a very distant examiner like me. Okay, because usually these patients are sterile. They don't have the infected like that. Okay, so I don't think so. It needs to be mentioned in a very specialized way. Okay, so like other of the things, yes, analgesia is very important. If you want to tell something more about analgesia, like we discussed about rib fracture management, hip fracture management. Okay, and use of erector spiny block, use of intercostal nerve block, paravertebral also. Actually, yes, epidural in the trauma. I don't think so.
Yes.
In which condition will you like to give epidural in the trauma patient immediately?
No, not in the trauma, not in the acute condition, but I was just thinking about if the patient has to go for the multiple surgeries and the polytrauma patients, we were used to give epidural, thoracic epidurals in these patients.
No, you are absolutely right. But you know, Tayyiba, just try to figure out the scenario. Okay, if it is in like in this discussion, our aim is trauma, our aim is emergency. Okay, so like I don't think so, because epidural is a definitive treatment, like definitive pain control. Okay, in that time you are actually focusing the block which are necessary for the transport, or which are leading to catastrophic events. Like for example, if patient has rib fracture, patient will not be able to breathe. Okay, so the things like that. So like intercostal nerve block, or like femoral nerve block for the positioning of the patient with hip fracture. These are actually more important aspects in trauma rather than epidural. Okay, because otherwise you can say your point is absolutely correct, but just try to use the word like antibiotics, like this epidural. Actually, you will not have time, I guarantee you, because in the exam and they will asking you trauma, there are hell of information which you actually have to tell. So the number of this one will be, I think, coming at the last. Okay, so okay, so I'm finishing the topic of trauma. I don't know anything we have missed. Anything else, Tayyiba, or anyone else, please, before we move to next aspect of burn? Yes.
No, sir. No, something about the venous thromboprophylaxis. If the surgeon or this must be the multidisciplinary approach, but when we must be thinking about this thromboprophylaxis.
Okay, sorry. A question of because I think we had discussed this before as well, but I will ask to you again. What is neurogenic pulmonary edema?
This occurs in the patients of head injury.
Okay. Because of? Yes, anyone else want to tell? Because this was
sympathetic discharge.
Please again, because your voice was distorted. Again, please say again.
Sir, this occurred due to excessive sympathetic discharge in patient with head trauma.
Okay, and leading to?
Leading to pulmonary edema. A disruption of alveolar capillaries and leading to pulmonary edema.
Yes. Okay. So this is one question they can ask you: neurogenic pulmonary edema. Okay. So how much time we have? I think burn we will discuss separately, because burn needs a lot of time. Okay. So any other a quick question I will ask. Okay. So if you have a patient with trauma for decompressive craniectomy, okay, decompressive craniectomy, that like what will be the, I think we have discussed this thing in detail in last few days. I don't think so. This is a very good question. I think we will finish our discussion today at this point, and we are not able to cover burn. We will discuss in detail burn in our next session. Tomorrow, actually, I'm on call, but if I am not having any assignment, we will have a class at the same time. Okay. If not, I will let you know. So tomorrow we will discuss burn. Okay, because this is very important topic. If I have because I have just tried to touch as many aspects as possible. Okay, So if I happen to miss anything, please do search it and even share with us. Okay. Just a second. I just told you what aspects. Yes. Just give me a second, please. Yes, trauma ATLS, trauma multidisciplinary team, FAST, and trauma radiology, trauma pain control, trauma airway management, and spinal cord injury and shock. Yes, yes, I think we can do this. What about spinal shock? We forgot. I forgot to do this. What is spinal shock?
This is basically areflexia below the lesion of injury to the cord. It may present as bradycardia and hypotension, but not in all the cases. This is not true shock. This is areflexia, basically.
No, I don't agree to you. What is the most dangerous thing in spinal shock? Is it areflexia is dangerous?
This is not a true shock, sir.
No, you're right. But actually, what are the things? You just think again. What are the problems related to spinal cord injury? This is spinal shock is because of spinal cord injury. Am I right?
Yes.
So what is the reason? What are like when there is sudden acute spinal cord injury? Okay. So one what are the things which are very important to tackle in that time? In addition to stabilization, we have discussed a lot. Okay. So spinal shock is because of severe sympathectomy below the level. Okay. Usually if the spinal cord at what level it finish? At L1, L2. Okay.
L1, L2. Yes.
So of course, whenever there is spinal cord injury, at for example, as high as possible, there will be shock. From where did you read this that there will be no shock?
That is neurogenic shock.
So that is neurogenic shock, which you are telling. That is basically peripheral vasodilatation, bradycardia, and hypotension.
So this is the spinal
That is
shock.
because of the.
That is the
No,
spinal
sir.
shock.
These
So spinal
two are
shock
the
and
different
neurogenic shock
things.
are separate things.
Are two different things. Yes.
Okay.
Sir.
Okay. So okay, whatever. So what about the neurogenic shock? Maybe I am wrong.
So this is basically loss of the sympathetic vascular tone, and this basically happens when the sympathetic nervous system has been damaged. And this occurs with the lesion at the level above. When this occurs, T6 levels are above. Then the patient presents with a hypotension, bradycardia, and peripheral vasodilatation. And in this case, patient is basically irresponsive or not responding towards the fluids. Resistant hypotension.
So what will you be doing that time? What will be the things which you have to give?
You can give inotropes or vasopressors to just meet the mean arterial pressure.
Okay, mainly vasopressors or inotropes or both?
Vasopressors mainly.
Mainly
no,
vasopressors.
Mainly.
And what about
yes,
steroids?
Because this is the sympathetic.
And what about steroids?
I have not. I am not remembering the
there will be
won't we need inotropes too? Because
inotropes too.
Basically,
if you are having high level, okay, if you have like injury in the thoracic region, you will be needing it. Okay.
Right, sir. I think Dr. Asim would like to add something.
Yes, Asim bhai, please tell.
Yes, Dr. Zishan, you are right, because the spinal shock is flaccid areflexia along with the neurogenic shock, and the neurogenic shock is alone because it is in initial phase there is higher sympathetic overactivity, hypertension, and tachycardia, and then it will go to the interruption, and there will be unopposed vagal tone because of a high level of injury, about to T2 to T5 level. And the SVR will low, and inotropism will decrease. And with the spinal shock, it will take like from 1 day to like 1 year. And for neurogenic shock, it is usually like 2 or 3 weeks. It will resolve. And for the spinal shock, and for the you are saying about the neuroprotection strategies, we have. You said that the steroids, and there is also therapeutic hypothermia, and along with vasopressor support.
No, therapeutic hypothermia? No.
Yes.
Because there will be hypothermia because of vasodilatation.
Yeah, but yes, there is hypothermia. Yes, but for the neuroprotection, we have to do therapeutic hypothermia.
No, that is, they don't mix up the things. Okay, don't mix up the things. Whenever there is spinal cord injury, the one aspect, there are few aspects which, you know, now we have to summarize what concept I had a little bit differentiation because I was combining it. Spinal shock, in my opinion, it's a combination of both motor, sensory, and vasomotor. Okay, both
Yes.
motor, sensory, and vasomotor. That's what I have concept of spinal shock. Okay, so when there is motor loss, one is acute phase and one is the chronic phase. Okay, in chronic phase there is development of this autonomic hyperreflexia. That which occur. Okay, so initially when there is more loss of motor, if it is occurring, it's not creating that much problem. The problem is further deterioration of the injury. Okay, and try to focus the reversible component. Okay, because it can be complete transaction or it can be incomplete. Okay, incomplete, like what is that called as incomplete? Brown-Sequard syndrome. What is that?
Brown-Sequard syndrome. Yes.
Okay.
So basically, yes.
Yes. Please tell.
So this is the loss of the motor below the level of injury on the ipsilateral side, but there is a preservation of the proprioception and the temperature, which are basically coming from the posterior side. So there is on the ipsilateral side, there is a motor deficit, but the proprioception is intact.
Yes. So in that case, like you will be giving, why you are giving steroid, high dose steroids?
For the prevention of cord edema, to prevent the cord edema.
Yes, it is actually because, you know, with passage of time, there are different studies, different trials, whatever. Okay, but in the exam, I think I suggest you that you should tell, okay, that there will be need of steroids to reduce the edema, which can possibly prevent further injury to the spinal cord. Okay, so that will be through the this one. Usually methylprednisolone is given. Okay, high dose, and then for the support of the hemodynamic effects, you need preferably vasopressor, and if it is higher, involving the cardio accelerative fibers, then you will be needing both inotropes and vasopressors as well. Okay, but if it is low, then you will be needing the this one vasopressor preferably. Okay, and because now that patient will be bedridden, so thromboprophylaxis will be very important. Okay, and then when you are using high dose steroid, there will be problem related to gut, and another thing will be that when there is
hypoglycemia.
No, sympathectomy, there will be overdriven activity of vagal. So that is also a reason of gastric acid. Okay. Increase vagal activity.
So, yes, hypersecretion of acids and gastritis would be there. So acid prophylaxis would and DVT prophylaxis and bed sores care. Also bowel and
now,
care.
you know, now this patient will be needing tracheostomy. This patient will be needing like all the long-term management in ICU, because gradually it will, because if it is having high spine, like it is involving cervical, it's depending on, now the patient will be dependent on ventilator. Okay, with passage of time, there are certain things which they do, even they place a laparoscopic placement of the diaphragm stimulator. Okay, just like the function of phrenic nerve, they are trying to do so that the ventilator dependency is finished. Okay, so these are the extra things, but immediate management of spinal shock will be supportive treatment, prevention of further injury. That's what actually I wanted to tell. That I had never thought that these are two separate that you are right, but actually in my concept, spinal, because I am a very simple person. I try to simplify the thing. Is in spinal cord there is presence of sensory tract, motor tract, and autonomic. Okay, so whenever
So
there is
exist. So they that's why they are mixed up in most of the topics. They coexist, neurogenic shock and spinal shock.
yes. Okay, so as high it will be, and as like you are just trying to have the preventable things. Okay, so I think we utilize this few more minutes. So inshallah.
One thing more. Can I add one more thing?
Yes, please.
Yeah, this one for the steroid, there is one also indication, because for the secondary injury prevention, and the level of the block also, because if the level is lower side, the ventilatory support or the vital capacity will be more whenever there is lower level of injury. So the edema, if it is it go bi-directional. So what happen if it is like in C3 C5 level, if it will go to the C3 level, so it will be definitive he will be ventilator dependent, that patient. So we have to avoid this also.
Yes, this is, and when you are giving naming the steroids, if there is combined head injury and spinal cord injury, then and you are giving high dose of steroids, then you have to decide between risk versus benefit. Because whenever you are giving steroids, there are chances of hyperglycemia. Okay, and so like you have to make a overall decision that whether you should be giving like how will you be anticipating. Okay, you may be needing insulin to control the blood sugars. Okay, so I think this is aspect which we had missed. Okay, and special scenarios. Yes, pregnant patient, what will happen? I don't think so any of you have seen this message which I had sent in the morning. By the way, I tell you something, I don't copy paste. Okay, so I just in the morning I was just thinking, and then I wrote it down, and then I send it. I am sending now in the chat box as well. So who hasn't seen it? Because if you keep the things points in your mind, it is easy for you to elaborate. Okay, so what's important? Amniotic fluid embolism, high risk. Okay, what else? Again, the same things, the consideration related to
consideration of life, monitoring of
and
left lateral position, airway management.
Airway management. If there is
thrombotic conditions
and antepartum hemorrhage can start. Am I right?
Yes, abortion can occur. So,
yes, Dr. Samer, Cauda equina syndrome. What is Cauda equina syndrome? Yes, who will tell?
Sir, Cauda equina syndrome occurs due to injury to the lumbosacral spinal nerve roots, so leading to bowel and bladder dysfunction in a patient.
Yes, usually like it was related to high concentration of lidocaine being used previously, but now it's not being used. Okay, okay, Dr. Samer. Okay, so what about elderly patient or pediatric patient?
Sir, again, the concerns of that age group concern about the airway, concern about the altered pharmacological, anatomical, and physiological aspects, and also hypothermia in both of the age groups, lethal triad, avoidance of lethal triad.
Like important points will be that you have to consider the anatomical, physiological, and pharmacological differences in pediatric age group. Usual in the trauma in adults, hypotension is the early sign. Okay, here hypotension usually will not occur actually, okay, or very late. So you cannot rely on the usual parameters to look for, and you have to very carefully calculate the fluid resuscitation. You have to be very careful. Everything should be very careful. Actually, if they ask this question, nothing to worry. You just have to tell them almost the same things, only the few differences which you have. Okay, pregnant patient, the same thing which we have discussed multiple times, that early cesarean section and left lateral tilter and anything like that. Okay, so like whenever there is, they can ask you in a different scenario. Okay, so what is fast scan?
So it is focus assessment sonography test.
For trauma, not
for
test.
trauma.
Yes, focus assessment via sonography for trauma.
Yes, sir.
Like, you know, don't be shocked. I was asked in my exam ERCP, and once upon a time I even forget in the exam what is ERCP. Okay, so don't worry, but you should be knowing these things. Okay,
Yes,
so
sir.
fast scan will be telling you in for abdomen, and the other radiological thing will be CT scan or MRI or chest X-ray. Okay, and in case of
blood in potential spaces in the abdominal thorax, like pericardial space, perihepatic, perisplenic, in the cul-de-sacs.
Yes. Okay. So they can ask you again the same things about it. Okay, I think it's enough discussion. Actually, my plan was to do this one as well, but I think because burn is a very important topic, we will discuss separately. Maybe, you know, if tomorrow, maybe I will put some other topic. Maybe I will go for the teams which we were thinking to discuss. Okay, so burn we will do day after tomorrow. Okay. The teams. Okay, Zishan, on your choice.
Right, sir. Got it.
So the
So
teams are secret. I will not tell you. Rapid response team, code blue team, acute pain service team, chronic pain service team, trauma team. Okay, critical care outreach team. Okay. So atypical topics, and also we can discuss MRI and anesthesia for outside operation room. Okay.
Okay.
Patient transfer we have discussed. Please prepare, which I don't know. You or any of you prepare the airlift, because I don't have the idea about airlift. Okay.
Okay, sir.
Because other things we discussed yesterday. Oh, okay. So thanks all of you for your presence, and inshallah tomorrow, if hopefully I will be free, so I will be. Otherwise, we will do next day after. Okay, rather than anesthesia like trauma, herniated disc, inflammation causing nerve root injury. Yes, you are right. Other causes of cardiac pneumonia. Yes, you are Dr. Samit. You are right. Okay. Okay, everyone. Thanks a lot, and you can find all the recordings on the YouTube channel. Okay, I share the link, and you can subscribe and you can follow the playlists, because in the playlist you will find a number of things. And for the international audience, I have made the English this playlist, so you will find all the recordings which are in the English. Okay, thank you very much. Bye bye.